All right, this is 7:04. We will get started. Good evening all to the Weekly Huddle session 58. My name is Anoop Agrawal. I'm a cardiologist at Care Hospital, Hyderabad. I'm joined in this session by my colleague and co-host for the huddle, Dr. Praneeth Polamuri. And a lot of attendees for today have been usual attendees of the Weekly Huddle. I'll still quickly go through a brief introduction of what the huddle is all about. The Weekly Huddle is an unscripted audience-level interaction where we address clinical scenarios that we encounter in our daily practice. We typically pick up a topic or a clinical case like what we have today, and we try to restrict our discussion around that. The basic premise of the huddle is to bring our casual hallway discussion to a more organized platform like this one, share our ideas so that we learn from each other. While we do welcome science and guidelines, with the huddle, we intend to help a physician translate established knowledge to clinical practice, taking local factors and practice patterns into account, kind of in a more pragmatic way. And this is not a speaker and audience model, rather than casual discussion, which means any of the attendees can raise their hand or unmute themselves to give their input. As a courtesy, you should wait for others to finish their thoughts before you unmute yourself. We host this session every Wednesday at 7 p.m. And I just got a feedback from one of the attendees that I'm speaking too fast. That is because I wanted to browse through the introduction much faster so that I can get to today's case. Okay, so that was a quick introduction about what we are doing at the huddle. And I'll brief you about today's case. This patient I saw last week. He is a 28-year-old male. He runs a small business outside Hyderabad in one of the tier 2 cities. His initial visit to Hyderabad was basically as an attendant to his mother who needed medical attention. And since he was in Hyderabad, he was like, might well get some routine evaluation done. This was his first encounter to a hospital or a doctor. So he got a routine package done that many of the hospitals offer. And some of the findings, some of the salient findings, I'm going to list it out. And that's the same thing I put it in the group as well. So first of all, he weighs around 120 kg. His BMI comes around 42. His blood pressure, which was recorded in the clinic, was 180 over 110. He got a routine panel of investigations. And I'm just telling you the pertinent ones. His HbA1c was noted to be 6.8 with a normal hemogram. His cholesterol profile showed LDL of 186 and a triglyceride of 234. His total cholesterol was about 250. So before he came to me, he actually saw an endocrinologist, because as a part of the package, the physician suggested him that because of your elevated HbA1c, you should seek an endocrinologist opinion for the so-called diagnosis of diabetes in him. And endocrinologist advised him to take metformin, 1000 milligrams daily, atorvastatin, 20 milligrams daily, and he suggested him to undergo bariatric surgery. And he also suggested, the endocrinologist also suggested the patient to go and meet a cardiologist for elevated blood pressure. That is how the patient came to me. During my interview, he said, I have mild dyspnea on exertion, but nothing too bothersome. He's able to maintain his daily activity. And if it wasn't for his mother, he probably wouldn't have sought any medical attention anyway. He does not have any obvious coronary risk factors except the one that I mentioned above. So with the given information, the diagnosis of metabolic syndrome was made. And here the discussion point which I wanted to bring for today's session is, what will be the best weight loss management strategy in this case? We know this patient should go for, or this person should go for weight loss management. The question here is, what is the best management strategy, understanding that this is this patient's first encounter to a clinical medicine, as to speak. He has never sought help for this thing before. The question is, what are our realistic goals? He currently weighs 120 plus kilograms with a BMI of around 42. What should be our realistic goals for the strategy that we offer to him? Second, what kind of diet and lifestyle modifications will work here? We talk about all the dietary restrictions and whatnot for weight loss. But now here we have got a person who is in super obese, if you will, in that category. So what kind of diet and lifestyle interventions or nutrition interventions that we can actually offer to this patient, which is going to make difference in real terms, not just something that we check box in our routine life. Just cutting down oil is probably not going to work in him. Third question is drug therapy. Should we start him now, like what has already been started, metformin, statin, or should we wait for some time? Or whether he will never need drug therapy if we are able to achieve weight loss. So should our focus be more on weight loss rather than drug therapy at this time? And do we foresee that he would never need these medications? And then the fourth question, which actually is pertinent to me, that's the whole reason why this patient came to me. I have two sizes BP curve in my office, and even the larger one could not fit his arm. And my blood pressure machine also gave a blood pressure reading of around 180 over 110. So the question is, how do we accurately assess his blood pressure, knowing that we typically don't have that extra large BP curve, which may be required for this subset of patients? So how do we handle those as well? Can we rely upon the current reading and put him on antihypertensive medications, or should we give him a second chance? Remember, this is the first time he is coming to the hospital. So I have got these questions and this discussion in my mind. I always start with my colleague Praneeth giving his thoughts, and then we go down the list to have other people share their thoughts as well. So Praneeth, the floor is yours.
Yeah, good evening, everyone. Interesting situation, Anoop. The age of the patient makes it challenging. As you already mentioned, the classic metabolic syndrome of diabetes, hypertension, dyslipidemia, and it is all because of the obesity. And obesity seems to be the root cause of all these things. And if we can, by all our efforts, can address the obesity, I believe all these issues will be resolved. But the challenge is how. First thing, we talk about all those things, but I believe the patient needs to be educated or highlighted the importance of what he is going through, because I believe he is unaware of and ignorant about his condition. And if he continues to go in the same path, he surely is going to have organ dysfunction. So, educating the patient and highlighting the importance of the issue and getting his willingness to accept the condition and take forward is going to be the key element. Because if we are talking about giving him drugs, therapy, and all those things, and then as a first encounter, he may not be accepting and he may not be complying with the advice that we are going to give. So, getting him into confidence, I believe, is the first step. Uh, Talking to him in his language which he can understand, and keeping him for follow up and get him into confidence, and then do it. Now, regarding weight management, lot of issues. Ideally speaking, he has a BMI more than 40, falls into morbid obesity. But again, as a first encounter, we cannot suggest him therapies, the so-called bariatric surgery, which is an indication for this thing. But lifestyle modification, exercise, etc., needs to be considered. I think a lot of these things need behavior modification, where patient understands this issue and comply with these things, because it's a very challenging task ahead. And unless he is willing to change, we ourselves bringing a change will be difficult. I think this is my take on this case. And a lot of behavioral therapy.
Thank you, Praneeth. Let me go down the list, and we have got few experts in today's panel, so we will go to them as well. But let me first get the mood set up first. We have Dr. Srinivas Raju here. He is a cardiologist at Care Hospital himself. Uh, Srinivas sir, this patient comes to you. Praneeth wants to do behavioral modification. He lives around 200 kilometers away from Hyderabad. And as soon as his mom's health needs are done, he's going to go back there. What is the realistic way for us to work with this patient? Srinivasan.
Yeah, Dr. Anoop, First and foremost, is it that it's only him who is obese, or his siblings and parents obesity?
So his mom is overweight but not obese.
Okay.
I have not met his other family members. He has got one sister whom he says is also a little bit chubby, but not to the degree that he is. That is the only thing I've inquired so far.
And from your history regarding his diet, did he show any signs of overeating?
Sir, I'm sure he is overeating. I did not delve that much detail into what he is eating. I assumed that his weight is because of him eating more than what his body requires.
Sure. In that case, if it is only due to overeating and not any other conditions like hypothyroidism, lack of physical activity, then we can suggest behavioral modification. But as Dr. Praneeth has said, it is a morbid obesity. I don't know to what extent the dietary patterns are going to change his obesity. Already is morbidly obese, and he's a diabetic now with high blood pressure, and then hyperlipidemia has set in, and he might even have osteoarthritis for that kind of obesity. So definitely he will require some intervention. First thing would be to straight away start treatment for hyperlipidemia, hypertension, and then diabetes. But for the obesity point, unless we take care of it in terms of surgery, I don't think behavioral modification is going to help him much. And what you had asked for the measurement of BP, right? I think there are cuff sizes which are available for such kind of patients, wherein the circumference is around 43 to 53 centimeters. That is the cuffs which are made for the thigh. Maybe you can use such kind of a cuff for.
Perfect. I think, sir, you got muted, but we got your point. Yes, sir, you have something else to add?
Right. I mean, just the BP part of it, was I audible on that?
Yes, you were audible about the BP cuff and that we need to get 43 to 52 centimeter
Yeah.
size cuff. Yeah.
Right.
But would you put him on medication right now?
Yes, medications for diabetes, hypertension, hyperlipidemia, and then dietary advice. But certainly down the line, we have to prepare him for the surgery. Since it's morbid obesity, I don't think only diet change would help him much down the line. That's
Right.
my.
Perfect. Thank you so much, sir. Dr. Chandramukhi is one of our colleague cardiologists at CARE as well. Chandramukhi ma'am, this patient comes to you. Do you have a 52 centimeter cuff in your OPD? And how would you take this patient with you?
Good evening to all. Thank you, Dr. Anoop. Yeah, when this patient comes, definitely I will advise him regarding the lifestyle modifications, intense exercise regime, and dietary patterns for the management of weight loss. And I will definitely start off the medications as already has been mentioned. And for BP measurement, as Srinivas has mentioned, we can use the thigh cuff, which is available. And if the thigh, we are not able to measure the BP, arm BP, then we can also measure the forearm BP. That is also like a reliable measure of BP if we do it in the supine position. So we can measure the forearm BP if we are not able to measure the arm BP. Thank you.
Perfect. Thank you so much, ma'am. Let me get a general physician's opinion here. We have Dr. Saini with us. Dr. Saini is a family physician at Gurgaon. Dr. Saini, thank you for joining. And if you could share your thoughts, if this patient were to visit you, how would you take this case?
Thanks, Anoop. Very interesting question that you put up in the posters today. So there was no option for me but to join today. We do see these kind of patients very often in our OPDs. And I think the question about BP cuff has been, a couple of options have been given. So I'm happy to, I didn't have an answer for that, so I'm happy to hear that. Now, whenever patient with the first diagnosis of a chronic disease comes to my OPD, I mentally prepare myself that this is going to take at least half an hour. And with this patient who has new onset diabetes and hyperlipidemia as well as blood pressure, it's going to take a minimum 1 hour. And I say this because this is what is the minimum time needed to do things right. To do all of the things that we have discussed so far, we have to build a rapport with this patient. Because this is not going to be a one-time thing. We cannot do wonders in this one visit that this patient is going to be perfectly all right after. So this is going to take multiple visits. This is going to take a trust building, and that takes time and effort and a relaxed conversation with the patient. And yes, I would like to again highlight this word called conversation, more than the advice, because lifestyle modification is a very personal thing. It's a very cultural thing. It's a very, very difficult thing for anyone to undergo. So it helps to have a conversation and first understand the context of the patient before we start advising. And even during education or imparting things, like ask patient, hey, what did you
Dr. Saini, your voice just started breaking. Last 10-15 seconds, your voice is breaking.
Okay, is it better now?
Yep, now it is. Yep, now it is good.
Okay. Right.
The questions
so
part. Yeah, the questions part.
Yeah, so conversation. We would like to have a conversation with the patient, and while educating, ask him what does he already know about these things, the blood pressure, cholesterol, and diabetes, and try to build upon what he already knows. And during this conversation, we can discover hooks. We can discover things that we can use to motivate him to do these drastic changes he would need to do in his life from now on. And those could be, let's say, if he has acidity issues. So we can say, see, all of this is linked with acidity. The moment you reduce weight, the moment you start exercising, you're going to see a lot of improvement in that. You can eat whatever you want after that. If you have sleep issues, they are going to get better. If it's a family thing, then we can inquire about if someone had chronic kidney disease or early deaths in the family, and we can use those to motivate the patient. Right now, he's not feeling anything, right? All of this blood pressure is just a number. This triglycerides is, again, just a number on the paper, and the sugar as well. So it's all like a bad dream for him. The moment he steps out of it and goes back to his own environment, he's probably going to, take a few days and forget about all of this. And it's going to be very easy for him to forget about all of it. So we need to link all of this to something that he personally experiences day in and day out, and that will help to build his motivation to bring about all of these changes. And the last thing I would like to add is that definitely we need to make initial steps easy for him. So most people, for example, think that exercise means that you have to get up early in the morning and do 50 minutes of yoga or intense walking or running. That's the typical image people have in their mind. So I definitely try to address that in the first visit that I am trying to address anyone. So it doesn't have to be morning, and it doesn't have to be one kind of exercise. Anything in the past.
Yeah, Dr. Saini, after like 5-10 minutes of you speak, your voice for some reason starts fading.
Okay.
Try again. Are you?
Yeah. How about now?
Yeah, now again it is better. We heard you. We just lost in the last 5-10 seconds as well, but we got your point. One question I have, Dr. Saini, for you is, One hour for this patient. How many visits are you going to charge him for?
So we just charge him for one visit, but we tried an experiment in which we said, okay, if you're going to discuss your annual health checkup, then we are going to charge twice as much. And some people agreed, some people didn't. So the point is that if we do this, then this patient is going to become very regular, and then next visits are going to be easier and easier. Let's take less of the time and effort of the doctor.
Perfect. All right. Thank you. We have Dr. Vrinda with us. Dr. Vrinda is an endocrinologist and my wife. Vrinda, what will you do? This patient comes to you, started on metformin and statin. How is this behavioral modification thing, and what are you going to do differently?
Hi, everyone. Good evening. So this patient's BMI is 42. So certainly, I think, as everybody has pitched in behavioral modification, but, from my point of view, I think he would need a little bit more than behavioral modification. So, of course, this patient has diabetes, A1C of 6.8, so which gives me the opportunity to discuss about maybe a couple of options for anti-diabetic medications, which also help with weight loss. So my thought process would be that how can I actually offer him the best of both worlds in terms of glycemic control as well as some weight loss. So if metformin is a great drug, but the weight loss data is not confirmatory with the drug. So today we have two classes of medications, SGLT2 inhibitors as well as the GLP-1 receptor agonist, approved for management of diabetes. One of the GLP-1 receptor agonists, which is available in India, and I have used it, is liraglutide, which is approved for weight loss. It's an anti-obesity medication, irrespective of presence or absence of diabetes. So I think, I would definitely bring up, the discussion about essentially starting this medication. Sometimes, and I do make sure that people understand that these medications are not going to work if we don't get up and moving or work on the lifestyle modification. So but I think it does give us an opportunity to actually help the patient in some way. Now, the restrictive part of using liraglutide in India is, of course, it's a daily injection and the cost. So I would offer this to the patient, as well as if the patient is hesitant either because of the cost issues or a daily injection, then maybe my next go-to would be to use an SGLT2 inhibitor, which is an oral medication associated with some 3 to 4 kilos weight loss. So I think my focus would be, how to help him the best, given that he has all these metabolic issues as well. So why not help him with pharmacotherapy, which can help him with both blood pressure, blood glucose, maybe improvement in the lipid parameters as well as weight loss.
So two questions I have for you, Vrinda. Number one is GLP-1 agonist as a monotherapy? Is that something that people should feel comfortable starting in this kind of patient subset?
Oh, yes, absolutely. I think we do have enough data, and I'm sure a clinical experience with the use of liraglutide. It's even been used for patients with pre-diabetes who desire some weight loss. So, before we even if patient desires weight loss as the primary goal and has some degree of dysglycemia. So I think we can make a cause for using liraglutide as a monotherapy. And that goes true for even patients, because now it is approved as a weight loss medication. So even for patients, say BMI more than 30, the guidelines say 27 plus if you have some comorbidities. So I think, I would be okay with starting liraglutide for these patients.
One question that came in the chat box is role of orlistat or any other weight loss medication.
Orlistat has long been approved. It's been on the market for a long time. Essentially, how it works is that it reduces the fat absorption in the gut. So it increases the fecal fat excretion. Now, in my opinion, it works if you eat a high fat diet. And, maybe, somebody can give me more information about it. But the limitation of this drug is that, in clinical practice, most of the patients, discontinue the drug because it requires that for weight loss, you should be taking 120 milligrams 3 times a day, with 3 meals of the day. The major limitation is that people discontinue it because of the gastrointestinal side effects, like a whole lot of concern for like flatulence, cramps, abdominal cramps, fecal incontinence. So a lot of times, we do, like in clinical practice, it's easy to get, it's a pill. So we do sometimes do write it, but most of the patients don't continue it long term. And plus the efficacy, like if you talk about how much weight will you lose with orlistat, it's much less compared to, the other medications that we have approved for weight loss.
And then the question of hypothyroidism and weight gain was brought up. This patient has a normal TSH, but what if he had hypothyroidism? Do you think correcting hypothyroidism, we could expect significant weight loss on this patient?
So this is what I tell patients also in the clinic, that levothyroxine is not a weight loss medication. So it's easy to put on weight when you're hypothyroid because of slowed metabolism. So when you essentially correct, or you are on the path of correcting hypothyroidism, I tell people to shed those extra calories away. You still need to work out. You still need to, practice lifestyle intervention. In itself, taking levothyroxine, sitting in the chair, does not reduce weight.
Perfect. Thank you so much, Vinda. We have Dr. Krishna Mohan with us. Dr. Krishna Mohan is a general surgeon with us with expertise in bariatric surgery. Sir, so far you heard the discussion, and our doctors want to do behavioral therapy on him. Somebody wants to put a GLP-1 agonist on him, and people are suggesting weight loss therapy and do some mental rehabilitation. Where does bariatric surgery stand on this? Do you think we should give him a chance, or because we have to be a little bit practical? This patient, as Dr. Saini said, the moment it's probably a bad dream for him. The moment he gets out of the hospital, after a few days or a few weeks, he's going to forget everything that is being discussed. And the whole notion of establishing rapport with him and bringing him again and again, this guy lives 200 to 50 kilometers away from here. The chances are we may or may not see him again. At the most, he may be showing to one of his next door doctor. So what role bariatric surgery play in these kind of patients? Dr. Krishna Mohan.
Yeah. Good evening, Dr. Anoop and all of you. I heard everyone, and I think I might have missed on his habitual history, like alcoholism and smoking. Do you have any inputs on that?
Yeah, non-smoker, non-alcoholic.
Okay. And second point is usually this drug therapy, because I'm doing this at least for the past 17 years, and whatever I understood in this population, particularly the subset of population, younger generation, what is our goal as a physician? What we wanted to treat metabolic syndrome, but what is your goal weight that you want to achieve with these drugs and lifestyle intervention or behavioral modification, whatever it is? Usually in the data, whatever it is available now, it is max 10 to 15% of excess weight loss one can achieve with all this drug treatment. Correct me if I'm wrong. And 42 BMI, and when you are looking at more than 25%, at least the reduction of excess weight loss, which is to be achieved as early as possible, I think he must be offered the surgery, the first point. The reason being, A young man of 28 years old going to a BMI of 42, very difficult to bring him back on behavioral modification even if you spend uh, for long sessions. The reason being, that that mood specifications and mood disturbances and disorientation of the focus on life itself. I see most of these people, usually I tell them, and they want very quick relief, whatever it is, whatever the advice you give to them. They are not, and you're also telling that he's 200 kilometers away from the place, from us. So we really need to live with him in the advice. Unless otherwise, the physician can live with him through advice. I think behavioral modification, achieving a slightest point of it is very, very difficult in my opinion. And second thing is, when you are aiming for 25% of excess weight loss to be achieved uh, in a short time, like say 6 months or 1 year, then how many sessions are required for really to counsel him and at 200 kilometers away? And these people also, not only the weight, they may sometimes, you see, because of this medication or whatever the behavioral modification we try, and these people may suddenly uh, depress also. And I see in most of the patients a mild depressive element. Slowly and slowly, more and more, it will increase as they fail in their attempts. So, but it is not that the moment we see the patient, we immediately jump onto the surgery. Definitely, I respect all the opinions. Let us try at least for 6 months. It's a time-bound program, it should be. What is the percentage of weight loss that you wanted to achieve with all your medical management and lifestyle modification? Must be time-bound program, and number one. And number two, how many sessions you wanted to give him? And number three, what kind of lifestyle intervention we are focusing on? Is it because some people may be working, some people may be still in studies? Uh, and I always feel the family history is very important in this, because without family support, it is very difficult to bring in any kind of behavioral modification in these people, because under 30s, usually the family influence is also much more, and that is the age they settle down with their uh, wedlock and marriages and all. So naturally, they are having very high aspirations, and the depression element, and very high mood swings. So in these people, at least we time bound medical management and lifestyle modification can be tried at least, maybe you see 6 months to 1 year. Suppose in the next 1 year, if we can't achieve even 10% of excess weight loss with all uh, the best of the best advice, then it is better to refer for bariatric surgery. If this patient comes to my clinic, definitely I will involve the multi specialty team. Along with that, I may take him at least, you see, first 3 months I will try to achieve minimum at least to reduce to 2-3 points of his BMI. If I see that there is reduction, that 3 points, then I will go for another 3 months, uh, slowly increasing my uh, waiting period for the surgery. Suppose if he fails that, even to achieve that 3 BMI reduction in first 3 months, then I think that there is something wrong, and we need to go a little aggressive in the approach, and slowly we will try to modify their thought process, the family thought process, think about bariatric surgery and the kind of results that they can give. So we put them onto preoperative, very low calorie diet, liquid diet, so that the goal orientation will be there. Because the moment you put them in on 800, 600 to 800 calories of very low calorie diet, they'll achieve weight loss drastically. in first 10 to 15 days, they may lose 6 to 8 kilos. Seeing that, they get motivated also. So that is the reason slowly then we motivate the family and as well as the patient to go for the bariatric surgery. This is how usually I take them to the path. But if they achieve the 3-point BMI in the first 3 months, definitely I want to wait for some more time. Let us see how best he can modify his lifestyle.
Thank you so much, sir. We will get back to you with more questions.
Yes,
Dr. Ravinder Reddy is here with us. He is a general surgeon and also he has got a special expertise in nutrition therapeutics. Sir, we are talking about behavioral modification. The problem that I have with this term is we need to give him specific instructions. He's weighing more than 120 kg. Just telling him go and reduce diet is not going to help. What specific thing can we do? And then you could also share your thoughts about drug therapy that Vrinda was mentioning and the role of bariatric surgery. Early means like within 6 months of diagnosis and whatnot. Ravinder, sir.
Yeah, thanks a lot, Anoop, and thanks for giving me the opportunity. If I remember correctly, I suspect it was the same patient we were talking about in the doctor's launch a couple of weeks ago, perhaps.
Yes,
Yeah,
absolutely.
yeah. Now, this 28-year-old guy is late to the hospital by 10 years, isn't he? Fortunately, I'm using the word fortunately, his mother was sick and he came to the hospital and showed himself, especially given his lifestyle of frequent alcohol intake and smoking. And a weight of 130. He's a sitting time bomb to develop very many things. And I'm not talking just the metabolic issues or the metabolic syndrome issues, but also he's more prone for a very early onset COPD or even obstructive sleep apnea. I mean,
Sir, just to interrupt you, there is no alcohol or smoking in this particular case. Sorry if I misspoke it somewhere. There is no smoking or alcohol in this case. Please go ahead.
Okay, I thought. Okay, I understood it as he takes alcohol regularly, and
I may have misspoken. If I said that, I may have misspoken. Sorry.
Okay. So even if he's not taking alcohol, given his age of just 28 years and BMI of huge of nearly 130 kilos, right? Any amount of intervention, any amount of counseling, generally, I'm not saying it's impossible, generally fails because we need the most important thing in such individuals is their motivation, not just for today, but even for the rest of his life. The very fact I'm saying for the rest of his life is probably because of the various hormones involved in his energy metabolism, like leptin, adiponectin, resistin, peptide YY, ghrelin, or even insulin. All these hormones, there is a disturbed milieu, internal milieu, and which has manifested as his obesity at such a young age. And perhaps he was obese even in his teenage years. If it is an acute onset obesity, the acute onset is probably within 2 or 3 years. Then that is a different thing. But if it is a chronic obesity, then I tend to agree with Dr. Krishnamon because any amount of lifestyle interventions, now lifestyle interventions can be divided into 3 aspects. Number 1 is diet, and that reduces anyone's weight up to 40 to 45%. Number 2 is fixed exercises, going to the gym or whatever, and the best time to exercise is whenever the person feels like, even though physiologically speaking, it's the best time is in the afternoons. But whenever the patient feels like or whenever he gets the time, but we need to familiarize the patients to the nuances of various exercises. It's not just simple walking or taking 10,000 steps. Even a newborn baby takes 5,000 to 6,000 steps, but still the baby is plumpy. So we need to explain to him the the extent of intensity of physical activity. Apart from these two, the other thing that has an effect on weight loss is the lifestyle, that is the physical activity. I'm not talking about exercise, but how active the person is from morning to evening. And this has to be for his lifetime. In addition to the GLP receptor agonists, right? There has been study on semaglutide, which we don't have in India, as you told me. The results on semaglutide, if I remember correctly, even after perhaps about 60 weeks or so, was just about 15%. The same thing can be achieved with other things. So at that point of time, when we were talking, when we were discussing, I didn't know he was only 28 years and he was 130. So again, I'm coming back to the attempts to inculcate the diet, physical exercise, and the physical activity in him. Perhaps he has to be very motivated, and he has to be familiarized. It doesn't matter it is one session or 1 hour, 2 hours, as many sessions as possible, as many sessions as it's required. If he doesn't have alcoholism, as you say, then he is a candidate. In fact, if you look at the indications for bariatric surgery, 30, I mean, the Western ones, if I remember correctly, please correct me, Dr. Krishna, is I think 37.5 and above without any risk factors, or 32.5 and above with risk factors. Now, he already has a couple of risk factors, as I understood. So, the moment he comes, of course, we can't offer him bariatric surgery. He will just run away to another person, or he'll not enter another hospital. Remember, he entered your clinic by default, or he entered the hospital because he had to as an attendant for his mother who was unwell. So he has to be motivated because the chances of failure after bariatric surgery are not bad, but they are still there. So we need to explain to him that there is a potential that he will become a lifelong cripple as far as nutrients in the form of macronutrients and micronutrients are concerned. So he needs a regular follow-up of every 6 months, that is twice a year. He needs to get his numbers done, looked at his weight, not just BMI, that can be totally wrong, but get his body mass analysis done, which I was talking to a couple of weeks ago on this forum. So he would be an ideal candidate for bariatric surgery, given his age. And given he's only 28, by the time he's 48, he'll develop this. I'll not be surprised if he develops liver dysfunction or at least hepatitis. And apart from that, his kidneys and lungs and heart, various other things. These are all the target organs. If he's lucky, he'll not develop any of the 11 or 12 cancers which are directly attributed as cause-effect relationship to obesity. Very fact that because there is an increased HSCRP in them, which is a very strong stimulant for various malignancies in him. So he needs to be counseled extensively. Regarding the GLP-1 peptide receptor antagonist, in this particular patient, I'm not very sure it will help him. But then we can try and see. And when when the person understands that he needs to take it in the injectable form for pretty long time, and also change his lifestyle. If he is very motivated, then yes, we can try that and see how it goes. Very close monitoring, which I suspect won't happen in this particular patient. So we can, at the same time, at the first or the second visit, put in a case of bariatric procedures. Bariatric procedures need not only be, of course, the conventional, the gold standard ones are now the surgical ones, but there is an evolving role for, there are some reports on balloon or even aspiration or even sleeve gastroplasty. All of them are through endoscope. And the good thing about these are that they are reversible. So all this can be offered to him, and whichever he thinks he wants, he can choose them. At the same time, we need to tell them that once bariatric surgery is done, it can be irreversible, and he needs to be under lifelong monitoring. That's about it at this moment, Anoop. Thank you.
Perfect. Thank you so much, Dr. Reddy. We have got Dr. Satyanarayana with us. He is a cardiothoracic surgeon with special expertise in nutrition. Dr. Satyanarayana, thank you for joining from Vizag. Please share your thoughts about this case that we are discussing today.
Yeah, at the outset, I'm thankful to Dr. Somraju and Dr. Anoop for allowing me to share some of my thoughts. In the outset there, because you have given 3 questions. One is, the first question is the weight loss strategy. In this one, Before that one, I want to confirm and also the quantification of the metabolic syndrome. In other words, according to the Gerald Raven, he satisfied 3 criteria out of 5. The only thing is I don't know, his HDL also must be low. So in that one, 4 criteria were satisfied. The one important thing is the another 2 important investigations are required for quantification. One is the abdominal ultrasound for fatty liver, the grading of the fatty liver. 2, the measurement of the insulin resistance by means of a HOMA or by means of a craft insulin. The reason for that one, why I'm insisting for a craft insulin and insulin resistance measurement, because obesity is not a calories related. Obesity is related to hormones. It is not the quantity of the food, as most of the people feel. It is the quality of the food that makes a difference, not the quantity of the food. If it is in the right quantity, even if you take excess, you will not be putting on weight. If it is the wrong diet and in the wrong quality of the food, and if you take even less, even if you drink water and air, you will put on weight. So this is the concept based on this one. The insulin resistance is the major factor for obesity, for hypertension, and also dyslipidemia. All these 3 are expressions, including the diabetes. All 4 are expressions of insulin problem. So unless we understand the insulin and its effect, insulin resistance is caused by the number 1 factor is insulin itself. The insulin is the hormone that is secreted to the excess amount of carbohydrates more than what we can digest. So ultimately it boils down to the simple weight management program with a diet and also the perfect lifestyle management counseling. I would like to do in this case, after measuring the fatty liver and also insulin resistance, how much it is there more than normal. Based on that one, strategy will be how much of a carbohydrates has to be manipulated for a given insulin resistance. Suppose I will call for the whole family counseling. If it is 28, I hope he is married, then along with the spouse. If it is not married, along with the parents, we have to spend at least a couple of hours with them. That's all what is required initially. We don't require a more number of hours. Based on this one, we give him a diet chart. We find out what are the foods that what he is interested, what are the things that he is taking all these years. Suppose if I can find where there is no carbohydrates in this one, or a minimal amount of carbohydrates along with the fiber, I would like to keep those foods for him. And I try to accommodate whatever the taste. I hope he's a vegetarian or non-vegetarian, I don't know. If it is a non-vegetarian guy, it is much easier for me to prescribe a diet. If it is a vegetarian, still I can do with a little modifications. I mean, with this kind of a thing, exercise alone is not good. Even if I suggest exercise, 10,000 steps has got no big meaning. And what we require is high intensity interval training, even 4 minutes a day, like that alternate days and 12 minutes in a week is sufficient. And most of the people can be motivated. High intensity interval training. And this is one of the things even for the weight reduction. Normally, classically, most of the people feel endurance exercise is the for weight loss, and then the strength training is the one for bodybuilding. But today there is enough evidence available. With the strength training, still you can lose the weight and also you can build the muscle and you can preserve the myocardium. That is much more important. The so-called endurance exercises will destroy the myocardium and will push them into the failure. So, in other words, in a nutshell, the second part is the BP measurements and other things. Once in a 6 weeks time, I can show the many people for the last 5 years I adopted, including myself. And the diabetic treatment, they don't require any type of a drugs. They can cut down fully, except the metformin, what he is on, may be continued. No other drug is required to control the blood sugar. Within 6 weeks time, usually his blood sugars will be within around 100, 120. And if we continue to do that one, it may fall down to 80 to 100. And second thing is you will definitely going to lose your criteria what you're putting and assure him to reduce the the BMI and also the weight. And also more than that one weight reduction, you will feel more energetic to do these things. So the other one is the third one, whatever that you are seeing, the bariatric surgery, I will still reserve it. That may be the last resort, not as a beginning, or even if it is just a 42, we can make it around 26, 25 within a few months, probably then he doesn't require, because as Dr. Reddy said, it is not just weight reduction. It's going to make him metabolically ill, and which we cannot even reverse him once we do the surgery. So in that way, the option number one is lifestyle modification with diet reduction, particularly low carbohydrate and healthy fat. Once if I give him a healthy fat, you will not feel hunger. Only 2 meals a day is sufficient. Just like Raju, what he's doing, intermittent fasting is a wonderful technique. You can adopt that one. You can see the much faster results. Intermittent fasting, if you do on alternate days like that one, it will give you wonderful results without feeling hunger. And also with losing a healthy weight, with not the drastic weight reduction and causes the problems. And you can expect it with intermittent fasting, low carbohydrate and healthy fat, not high fat, healthy fat with adequate amount of proteins. This is the combination along with the exercise based on his motivation. 12 minutes in a week, that's all sufficient enough with a high intensity interval training. Thank you very much for this opportunity.
Thank you so much, Dr. Satyanarayana. That was really exhaustive, and some of the points which truly speaking are new for me, and I believe a lot of us. We have Dr. Radha with us. Dr. Radha is a dietetics expert. Dr. Radha, if this patient had to come to you, what do you think between you and the patient and the diet? Do you think we can achieve what we want to achieve in this particular patient?
Thank you so much, Anoop. Having seen many of such patients, what I formally feel is, in my opinion, what Dr. Krishnamohan has said and what Dr. Ravinder said is right, actually. For these patients, it's a lot of weight and a good amount of time is required to keep up their motivation levels. Initially, yes, it's a little on the higher side and they do lose weight, so uh, they do motivate themselves and it's lost. But after that, after a while, then they lose that track and they go back. So always initially to motivate them and really see what is the kind of effect that would have on them with a diet. Yeah, if you're taking them for a bariatric surgery, a liquid diet is advised, a very low calorie diet, as Dr. Krishnamohan said. But otherwise, a regular diet, a low calorie LCD, not a very low calorie, but an LCD diet can be advised, and these patients do lose weight. But then, keeping in view the complications that would arise, that check them out for 3 months and then again tell them that this is one way of psychologically making them want a bariatric surgery. Because the first instance that you tell them that chalo, you go for a bariatric surgery, then they'll say no, that is not our first line of option. But then you give them a positive idea of weight loss and then ask them that you can do, but this is the length of time that you would take in. But these are the medications that you have to go on. These are the positive complications. And you are eligible for a bariatric surgery where you'll have faster results. And then for maintaining, you kind of follow a low calorie diet is something that we can advise. As as Dr. I think it is Dr. Satyanarayana from Vizag. I actually lost his name. Uh, what Sir said is doing intermittent fasting is a mode. End of the day, calorie restriction. Okay, that is what daily calorie restriction, DCR, is most essential for any one of us, be it our patient or our own selves. So how you do this calorie restriction, by a regular diet timing or by an intermittent fasting? Yes, go on. That's just a mode of bringing in. If you're used to eating a lot of, you have this habit of binge eating, then fine, calorie restrictions in terms of intermittent fasting can work for them. The time restricted one, intermittent fasting is something called as a time restricted kind of strategy. But then end of the day, that same 1,000 calories has to be given to them, or 1,200 calories has to be given to them within that time span or as a regular pattern. So that is what, but I too agree on the point that probably for this patient, a bariatric surgery would do greater benefit than just saying diet and diet and diet. It doesn't work for everybody.
Thank you so much, Dr. Radha. And truly speaking, I myself have almost 20 questions that I can ask to the audience member who have shared their thoughts so far. But we are going to run out of time. So I request each one of us that please be active on the WhatsApp group. I will be posting few of the questions, particularly for Dr. Radha, Dr. Krishna Mohan, and many others. So that we finish this session in a reasonable time frame, but still continue our thoughts so that most of our questions or concerns are answered. May I ask Dr. Somaraju to unmute himself and share his thoughts about today's case and the discussion that we had. Somaraju, sir.
Anoop, thanks for asking me. And while I'm not a specialist on say classical terms, I see significant number of patients with this type of problem that you are facing. And I must tell you, in the last few decades, I had to resort to bariatric surgery extremely rarely. And then I believe bariatric surgery is not to be taken for granted. There is a gut-brain connection. Stomach, to take away some part of the stomach, they are not normal people. So I resort to that as a last chance. And then when I was faced with a patient like this, I won't go into details except telling you, I do ask them, tell me your typical day, tell me your typical week. And then somebody pointed out that they have, psychologically, some of them are not normal. Their work, what they do, and their work atmosphere, workplace, the manager under whom they work, the friendships and colleagues, and then help of psychologist as part and parcel of how we deal with them. And one of the members of our outpatient team should be calling them every week initially. And when they think that they are falling in line, maybe less often. But they don't have to come to you every time. And somebody pointed out, what do you charge? And be flexible on those issues. Then with the help of our own nutritionist, Mrs. Vashistri and Dr. Satyanarayana, 95% or more of the people, they never needed to go for anything like bariatric surgery. And most of the time, we were able to say, I must say 90% and above, we were able to get them back to near normal weight or normal weight. And then obstructive sleep apnea and psychological problems are extremely common in them. Obstructive sleep apnea is not just a sleep problem. It is a metabolic problem. It is a whole body problem. It also contributes to even obesity. Because of the lack of time, I won't take more time, except telling you, food is everything. Food is medicine. Wellness medicine requires food alterations are fundamental, and physical activity, somebody pointed, I think Dr. Radha, physical activity is fundamentally important. Physical activity is not the same thing as formal exercise programs. And I'll want to know what he does, how he spends his day, and what is his work atmosphere. I'll leave it here, and maybe some other time we'll talk more. Thank you.
Thank you so much, sir. I think this was one of the most exhaustive discussion that we had. There were a lot of points that needs to be rediscussed and dissected out a little bit more. I have shared the link of our WhatsApp group. So if anybody in the audience today who is not a part of it, please open the chat box on this and you should be able to join the WhatsApp link. I hope that we continue our discussion in the group as well. It's 8:03, so unless anybody has got any very important point to share right now, please raise your hand or unmute yourself. Maybe we can be online for one more minute and then we will close it off so that we stay on time. While you gather your thought, may I ask my co-host Praneeth to summarize today's discussion and take home points for this.
Yeah, Anup, very interesting discussion. A lot of points to learn. The different perspectives from everyone was quite interesting. Obesity by itself as a disease or a syndrome and its implications on health aspects and the long-term goal, or it's like a chronic disease where patient has to live with it and we have to be with the patient, counseling them. Various therapies starting from lifestyle, behavior, and giving them practical timelines of what your goals are, how long you want to achieve them, and how you can achieve your goals with various therapies, both discussing the pros and cons, and keeping the options open to the patient and engaging with them, trying to know what his requirements are, and engaging the rapport or getting the connect with the patient is extremely important to succeed both as a patient and as a doctor to achieve the goals what he needs. So yeah, definitely very interesting and many things to learn. I hope the group will be discussing many things about this obesity syndrome.
Perfect. Thank you all for joining, and my special thanks to the guests who took their time for this discussion. I really appreciate you sharing your thoughts. And if you don't mind, continue with your thoughts and answer any questions that may have offline once we close this session. To let people know that we host this session every Wednesday at 7 p.m. So if you do want to join in the future, you can use the same link that you used to log in this time, and it should work for the future session as well. I hope that I will be able to send you invitations for the future session. If I won't, that's a mistake on my part. All the previous discussion, this is our 58th session, all the previous discussion are recorded, and most of them are uploaded online or YouTube or podcast. And if you search with the name The Weekly Huddle, you should be able to go in there in case if you want to listen to them during your dead time. All those are the same kind of casual discussion that we had today. Having said that, I thank all of you and wish you a good evening. And we will see you next Wednesday as well. And we hope to see you on the group with more discussion. Thank you so much for joining today. Good night.